Good morning. I'd like to call the meeting of the Senate Health and Human Services Committee to order. It is it's Tuesday, January 21st, 2025, and we are having our first Senate Health and Human Services Committee meeting of the new session. And I'd like to welcome the public to our hearing and welcome to our new committee members. We have a new DFL member and 3 new Republican members. So welcome all to the committee. Before we get started, I wanted to go through just a few of the things that we've discussed with co-chair Senator Utke and myself about how we're doing our co-chairing agreement. And just so everybody is clear, we're going to be rotating chairs at each meeting, at each committee hearing. We'll rotate the gavel, so I'll have the gavel today, and Senator Co-Chair Utke will have the gavel on Thursday. We will be scheduling committee hearings and creating agendas together with the agreement of both chairs. So when you see something posted, you can be assured that Senator Utke and I have worked together on creating the agenda. Since we are now a committee of 12, we have to have a vote of 7 members of the committee to pass bills out. And other motions, when we are working on a bill, will typically require a majority of members present, and that continues on. But to pass the bills out, we need a vote of 7 members of the committee. We will offer hybrid hearings, as we have in the past, on days when we are hearing member bills. And we have 2 committee administrators now who are working together closely, and they will be doing things pretty much as we have done them in past sessions. So you won't see a lot of difference for members of the public. And then just a reminder to look closely at hearing postings for any information and directions that may differ from prior sessions, and make sure that you sign up for the committee listserv so that you receive all of the information. I'm really looking forward to a continuation of robust and collegial discussion that we've had in this committee over the past 2 sessions, and look forward to hearing from the new members as well. And also looking forward to the work that we're going to do this session in partnership with Co-Chair Utke. So before we get started, we do have a very full agenda today, but before we get started, I'd like to do member introductions, and also if we can quickly go through, we have a lot of new faces at the table from our staff as well. So first, though, let's do member introductions, and I'll just start. I'm Melissa Wickland. I represent Senate District 51. That's Bloomington, Richfield, and a little bit of Minneapolis. And so today I'd like to keep the introductions to be brief, since we do have a lot to cover today. So let's start. Senator Gruenhagen, would you start with an introduction, please?
Thank you, Madam Chair. Yeah, I'm Senator Glenn Gruenhagen, District 17, which is southwest of the metro area. I got a little bit of Carver, McLeod, Sibley, a little bit of Meeker, and a little bit of Wright County. So, and I did serve on the HHS committee when I was in the House for about 6 terms. And although I'm new to this committee, I saw a lot of experience in that particular area. Nice to be here. Thank you.
Thank you. Senator Kupek.
Sure. Senator Rob Kupek. I represent Senate District 4, which is most of Clay and a portion of Becker County, Moorhead, over to Detroit Lakes.
Senator Curran.
And I'm Senator Mark Curran, represent Chisago and Isanti counties, and I've served 3 years voluntarily on HHS prior to the last session. I'm happy to be here. Thank you.
Senator Bolden.
Good morning. I'm Liz Bolden. I represent District 25, which is most of Rochester and some areas north. Happy to continue on this committee.
Senator Liskey.
Senator Bill Liskey. I represent Senate District 58, which consists of the southern part of Dakota County, the northern part of Rice County, and a little bit of Goodhue and Scott County.
Bryce Hinkst, I am the GOP CA.
Good morning, Senator Paul Etke. I represent District 5 in northwestern part of the state, which includes all or parts of Becker, Hubbard, Cass, Todd, Wadena, and Morrison counties. So welcome.
I'm Anna Burke. I'm the DFL Committee Administrator.
Haley Ryan, CLA for HHS.
Elise Mann, Senate District 50, which is Bloomington and Edina.
I am Dennis Vessel, and I am the fiscal analyst for the committee.
I'm Nolan Hudala. I am nonpartisan Senate counsel for the committee. My area of focus, there are three of us, is health insurance. So it'd be pieces of the Department of Health that relate to HMOs, utilization review, and then within the Department of Human Services, it would be healthcare administration, so provider reimbursement, hospitals, benefit sets.
I am Allie Hoffman-Litchie. I'm also nonpartisan Senate counsel. I am your DCYF counsel, and I also do homelessness, mental health, and DHS central office and inspector general.
Hi, I'm Erica Heichel, nonpartisan Senate counsel, and I'll be working mainly on Department of Health issues.
Good morning, Jim Abler from Anoka. What's that saying, may you live in interesting times? I think we are. Just in this committee, we have all these different jurisdictions and 3 different departments that really none of us understand. At least I don't understand very well. Maybe nobody really does, but we're getting there. And then you got the new co-thing and the House. And anyway, so I'm hoping we get some good stuff done. Thank you.
Good morning. Senator Lindsay Port, represent District 55 in Burnsville and Savage.
Great. And also, I'd like to see if we could have the people who sit in the back. We have new pages this year. If you could come forward and please introduce yourself to the.
Hi, committee page, Perrin King.
Committee page, William Battle.
Committee page, Elizabeth Rosemark.
Thank you very much. And they serve such an important role in our committee. We always have a lot to keep track of. So, and then we also have at the table in the back, we have our DFL researcher, and Bryce is also doing that work as researcher. So Emily Spiteri is our DFL researcher. I think that covers everybody. So, well, let us get started with our first presentation today. We have the Department of Health and topics related to Department of Health on the agenda today. So first, we're going to start off with an agency overview. And we have Deputy Commissioner Wendy Underwood here to present. Commissioner Underwood.
Hi, thank you so much, Chair and members. For the record, I am Wendy Underwood, Deputy Commissioner for the Minnesota Department of Health. Something I already have in common with a lot of you is that I am new to this committee too. So thank you so much for having me. It is my goal to move quickly through our agency overview so we can really get to the good stuff with our other presentations this morning. But to do that first, I want to just establish that our mission at the Department of Health is to protect, maintain, and improve the health of all Minnesotans. And so we're going to do just a brief overview on public health and then get to the great work MDH does every day to deliver on this mission. And so what does that really mean? What determines our health? This pie chart here shows how many factors influence our health. Notably, it's the social and economic factors like education, income, and employment, and health behaviors like our diet or use of alcohol that make up 70% of what determines our health. And yet, when we discuss big health issues of the day, we tend to focus on clinical care. Oh, that's okay. Oh, thanks. So when we talk about public health and health care, I just want to reiterate that MDH addresses the issues of that public health, those things that are upstream, focusing on prevention, working with communities to promote wellness, and tracking overall population health. And health care is focused on the individual, on their individual treatment and their individual quality of life. Both are important. And there's lots more we could talk about. Specifically with public health in Minnesota and in recognizing the work of this committee, we want to just acknowledge how our great colleagues at the Department of Human Services provide medical coverage, for example, to a child with measles, while at the Department of Public Health, we're providing information to parents about immunizations. I do want to just take a second to address specifically chronic conditions and public health in Minnesota. Public health is that recognition that conditions like diabetes, asthma, high blood pressure, and obesity are closely tied to where we live, work, our daily activities, and our behaviors. Public health is also impacted by a person's access to healthy food, by having meaningful work and a good wage, and is impacted if a person experiences violence or trauma. Along with behaviors and one's environment, a person's health is also due to societal factors. Do you have access to health care? Do you have access to meaningful work? Are you living with stress from discrimination or racism or trauma? All of these things create us and our individual health, which leads us to the Minnesota paradox. This is our challenge, where that despite being one of the healthier states in the nation, Minnesota still has some of the worst health disparities in the country. I'm not going to share a lot of stats, but there are a couple that are important to really make this point. For example, in Minnesota, Black women are 2.5 times more likely than white women to die of breast cancer within 5 years of diagnosis. Among those under the age of 65, when they've died, the asthma death rate for African American Minnesotans is 3 times higher than that of white Minnesotans. And there's a lot more statistics like that that we are going to be sharing throughout this session. So how do we tackle all of this at the Department of Health? We are organized into 5 bureaus, which are focused on protecting, maintaining, and improving the health of all Minnesotans. We have over 1,800 staff, which include nurses, doctors, health educators, biologists, chemists, epidemiologists, engineers, and laboratorians. We operate programs that prevent infectious disease like measles and influenza, and we operate programs to prevent chronic disease like cancer, diabetes, and stroke. We work hard to ensure clean water and air, safe food, quality health care, and healthy living. Critical to all of this are our partnerships, particularly with local public health departments, tribal governments, and the federal government. Our partnership is also important with healthcare delivery organizations in both acute and long-term care and other health-related organizations. And then lastly, we believe that health is in all policy. Population health outcomes are correlated to public policy work, so we work closely with many state agencies to help ensure conditions in which all people can be healthy. So I am not going to read all of this. These slides are meant as a resource for you, but I want to just highlight a couple of things within each of our bureaus. Our Health Protection Bureau is home to environmental health, where we inspect, test, and provide technical assistance to nearly 7,000 public water systems, and we ensure safe water, safe food, lodging, and swimming pools in 26,000 establishments statewide. These are folks right in your communities doing important public health work every day. We also have here the Infectious Disease Epidemiology, Prevention, and Control Division, where we maintain a 24/7 system to detect, investigate, and control diseases such as measles, bacterial meningitis, norovirus, E. coli, rabies, Lyme disease, avian influenza, and sexually transmitted diseases. Just in 2024 alone, this team had a total of 624 investigations across these areas. That's a lot. This group also coordinates a program that provides free vaccinations to nearly half of Minnesota's children. And you're going to hear more about this in a minute, are very engaged with over 2,000 farm workers potentially exposed to avian influenza on poultry and dairy farms. And then lastly, in this area is our public health lab, which you're always welcome to come join us for a tour if you haven't been. But this is where we screen 60,000 newborns for 63 conditions annually. And just last year tested almost 100,000, had almost 100,000 tests performed to identify infectious disease trends and outbreaks. Our next area is the Health Improvement Bureau, where we have our Children and Family Health Division, which provides things like nutrition services and home visiting services. We have our Health Promotion and Chronic Disease Division. This is where we address cancer, stroke, brain injury, diabetes, Alzheimer's, and much more. This is also where our State Health Improvement Program lives, which promotes policy, systems, and environmental changes with 87 counties and 10 tribal nations, and involves collaboration with over 6,000 local partners, such as schools and work sites. And then also in this area is our Substance Use, Injury, and Violence Prevention Division. This area oversees things like our 988 Suicide and Crisis Lifeline, our Tobacco Quit Line, and also has a number of significant partnerships with other areas of state, local, tribal, and federal governments. Our Health Systems Bureau is home to our Health Policy Division. This team supports things like our Office of Vital Records, which I want to share since the law came into effect in mid-year 2024. They provided over 3,000 original birth records to adoptees in response to that new law change, which is really incredible, in addition to what they do every day. But I wanted to share that in particular. This division also supports our rural healthcare work and publishes really important reports and information on healthcare market impacts. You're going to hear more about the 340B report and prescription drug pricing. We also have in this bureau our Health Regulation Division, which monitors nearly 4,700 hospitals, assisted living facilities, and nursing homes for safety and quality care. And then they inspect, license, and register thousands of different healthcare professionals or health professionals. This includes nursing assistants. It includes tattoo artists, funeral establishments, and spoken language health interpreters. A very, very wide array. Our next area is the Health Equity Bureau, which supports work across the agency to ensure all Minnesotans can live a healthy life in their community, regardless of whether they live in a rural or urban area, regardless of a disability or of an income level. This bureau also works very closely with local public health, tribal nations, and community-based organizations to help ensure efforts to connect with all people in a community are successful. This may include ways to reach seniors who are more homebound or people struggling with a chronic illness. You're going to hear more about work in this area in the next presentation. And then lastly, but very importantly, is our Operations Bureau, which is where we support the entire agency through our human resources, facilities, communications, emergency response, and much more. This one was a last-minute ad, but just a very exciting a map that we have of a real commitment over this last year to have MDH leadership visit in community, in local offices of each of your counties, or almost. We got super close. We saved some in the metro for the winter months. To really spend time together to appreciate the unique challenges of individual counties and tribal nations, so we can really bring that information back and drive forward our priorities and policies to support every unique need. We were asked to also provide an update on the Center for Healthcare Affordability, and I know my colleague Diane Rydrick will look forward to being before this committee in the future, but couldn't be here today. So I want to just acknowledge that we are so appreciative of the legislature's acknowledgement of the unsustainability of healthcare spending in Minnesota and your direction to us to establish this Center for Healthcare Affordability. As you know, the cost of health care generally rises faster than inflation, and the burden that places on individuals, families, and employers is very real and growing. For too many people, their care decisions are driven by fear about costs, and that can lead to poorer health overall. Since this language passed, we've gone through a careful process of talking to a wide range of stakeholders: employers, labor unions, providers, payers, consumer advocates, and other states who have done this before us, to get their input on how we should structure this work and where they think the opportunities lie to develop evidence-based solutions to high and rising healthcare spending. These conversations have shaped the approach we'll be taking to this work. In particular, they've reinforced the importance of centering individual and family voices and impacts as we move ahead, while also pulling together a strong advisory body that includes those with technical expertise. I am pleased to share that we have hired a director for the center, an experienced leader and convener who is starting at the end of this month, which we're very excited about. And the next steps will include the establishment of our advisory bodies and having community conversations about the impact of high healthcare costs on families and employers. And we look forward to working with you in that process. And then just lastly, after all of that information and just tiny snippets of our vast work, the reality is when we are most successful, you are not seeing us. Right? I mean, we are capturing the risks in water and food. We're identifying potential spreads of diseases. We're helping babies and little kids with nutrition and support. And so that is our success, which is tricky because the work needs awareness, it needs the financial support, it needs strong policy support. So we look forward to digging into a lot more of this work just later, right now, and in the coming months.
Thank you very much. Yeah, one of the reasons we thought would be good to have agency overviews this week is to be able to get started on understanding what each agency does as we have future discussions about budget or bills that affect different agencies. And thank you very much for providing the comprehensive kind of summary of the what the different bureaus do, so that we have that information as we go forward. And members, if we can keep it to a few minutes of questions, we can do that. Senator Gruenhagen.
Well, thank you, Madam Chair. Thanks for the presentation, Commissioner. I've been involved with the healthcare industry from an insurance standpoint since 1978. And, I'm sure you're aware there's a study out there, and you can look it up on the internet, that we're going to be more than 2,000 physicians short in Minnesota by 2030, according to this report. There's a number of reasons for that: aging population growth, but one of them is burnout. And Star Tribune a few years ago had a article. One of the reasons the doctors are burning out is the amount of excessive paperwork that has to be done. Well-intended, I think, but I think it's getting overdone between Obamacare and the HMOs and everything. So, you know, in my studies, I think now over 40 cents of every dollar of health insurance premium does not go to the doctor-patient relationship. Instead, it goes to a bureaucracy to micromanage the doctor-patient relationship. So we're spending almost half of every premium dollar on bureaucracy, okay? And Obamacare only made it worse, both at state and federal level. So I think all of us need to understand that adding layers and layers of bureaucracy onto the healthcare system is one of the reasons that we're hurting our healthcare system in terms of actual patient and doctor access. And that going forward, if we continue to do this, we're going to just see more and more doctors leave, fewer and fewer come in, and micromanaging them on every aspect has a negative consequence going forward. So do you have any solution to that shortage of 2,000 doctors, Commissioner?
Commissioner Underwood.
Thank you, Chair and Senator. Thank you so much. I want to just recognize, in a room full of public health professionals, your recognition of burnout is very much appreciated, for sure. I can't specifically answer to great detail your question right now. We do have, and particularly in our Office of Rural Healthcare, we do have a number of programs to support healthcare professionals where they're at, to support them staying in their communities and to continuing in their careers, which can be very difficult anywhere, but particularly in our more rural areas. So I appreciate you acknowledging that growing shortage.
So anything else? I think that there are different research opportunities that are going on at the Department of Health about administrative costs and low-value services, things like that, to try and bring in information about what could be helpful to reduce some of those costs. And then we also, through the Department of Health, have different workforce programs to encourage more people to go into the field, like loan forgiveness and other ways to strengthen the workforce that way. Senator Gruenhagen.
Yeah, well, thank you. Thanks for the response, and thank you, Madam Chair. Yeah, the other thing to understand, and I've attended a number of conferences on healthcare where doctors spoke of where they're being micromanaged to provide services that provide the highest reimbursement for the hospital or the clinic at the time rather than what the patient needs. And these were experienced doctors. And the reason they're doing that is they're no longer independent doctors, they're employees. And the administration is micromanaging healthcare services in some cases that bring in the most revenue rather than what the patient actually needs. So I think it's another area of concern that hopefully we can address, because doctors wind up in this box, according to them, and it's hard to them to actually apply the health care that the patient needs rather than getting the approval and the micromanagement of a bureaucracy. Thank you.
Thanks. Are there any other questions for Commissioner Underwood? Senator Abler.
Well, thanks, Madam Chair, and I know we're trying to be brief, but I just want to, I wasn't going to mention, but I'll pile on the administrative cost thing. I mean, there are a few levers that we have to really control costs. That's something that we really have to get after, and I think it's opportunistic on the part of some of these middle person companies that ostensibly are going to make it better, by managing and control costs. And bottom line is that America is amongst the least healthy and one of the most expensive to not be healthy. And I think if we could, as a committee, find some way to press upon the system to stop imposing some of those restrictions, we might actually find that the Healthcare Affordability Task Force might work better and so on. And I have a few ideas later, but I just wanted to, you provoked Commissioner, welcome. A lot of work, and you have quite a stable of work to do there, which I admire for that. But so you mentioned health disparities, and I just am ask a question for some follow-up information. I've been here a long time. We discussed health disparities in 1999, and there was efforts then to deal with, diabetes and whatever, and we've piled on and layered on all kinds of health disparity programs. Again, looking at the outcomes of all that. I know the department measures some of those things, but it'd be interesting to see how we're doing.
Yeah.
And so each time we have an idea, if we only had this special outreach to this particular group or that group, to see if it actually is working, especially now as we're looking at a time of a little leanness, is it working? And are we better to consolidate? I know some things have been broken out. So going forward, as we try to actually deal with the disparities, which are horrible for some of these particular groups, it'd be interesting to see how we doing, and is there just some data? So you can comment, but we can do a lot of that offline, but I think it's a question that the committee would benefit by understanding. So thank you, Madam Chair.
Commissioner.
Thank you, Madam Chair. Thank you, Senator Abler. I really appreciate that comment. And yes, we do have significant data showing where things are working and where we still have work to do. We did recently publish a number of legislative reports, some of which are coming before this committee today, and we'll continue to engage with you on this important topic.
Thank you. Now, thank you again for presenting, and look forward to working with you more. And now we'll move to a more general discussion about public health system development in Minnesota. There was a recent report that came out on this topic, and I thought that it would be a good way to share information about this report with the committee and get a chance to talk more about the importance of public health. So welcome to the committee. I have Chelsea Huntley is the director, and Nick Kelly, public health administrator, and from City of Bloomington. So I'm not sure which person wants to go first, but please go ahead and introduce yourself for the record.
Good morning, Madam Chair and members of the committee. My name, for the record, is Chelsea Huntley, Huntley. Super pleased to be here today with my colleague Nick to present this report. We're going to give you a little sneak peek today into some of the strengths and challenges of our system and talk about how we are working together to provide a more seamless, responsive, publicly supported system. Like Deputy Commissioner Underwood, we're going to start with the basics. We believe that every Minnesotan should have the opportunity to be their healthiest, regardless of who they are and where they live. That's why we're here together and why we continue to work on these important issues. Where we live really provides the building blocks for long-term health and well-being, including protection from infectious diseases, environmental threats, clean water, strong schools, sustaining jobs, community connectedness, access to healthcare, and other important community supports. In public health, we work to change the surroundings for the better so that it's easier for all of us to be our healthiest. And there's really nothing that we, as public health professionals, can't positively impact. We use our education and expertise to look beyond that individual health to identify patterns across entire communities, to diagnose population health issues, and help communities identify fixes that can help thousands of people at a time and prevent health issues before they start. To do that, we bring leaders together and cooperate with community members, elected officials like yourself, healthcare workers, businesses, and more to identify and implement shared solutions to help communities thrive. I wish our colleague, Commissioner Taylor Clark from Stearns County, was here today. She works with us, but is at a board meeting today, and you can see her quote there on how she would describe the role and value of public health. And while we know that there's nothing that public health can't positively impact, we also know that our system is out of date. As mentioned earlier, the disparities in one of the healthiest states of the nation, some people, groups, and communities don't have a fair shot at health, partly because of how our public health system is structured. Our approach to public health was designed almost 50 years ago, and clearly a lot has changed since then. In 1976, IBM introduced the first laser printer, and the first Ford Fiesta went into production. And many of today's public leaders, like myself, weren't even born yet. The way we share and exchange information has changed dramatically. The way we take in news and information has changed, and the sources we consult are wildly different. And the public expects that the content and services are convenient to them, specific to their needs, and they expect that we work with them to find out what they want. And the way we do public health in Minnesota wasn't built for today's needs, and it really can't anticipate tomorrow's. Not to mention, public health also expects us to cooperate with each other to get the job done, and that includes tribal nations, something public health didn't address in the mid-1970s. When we don't appear to be operating in today's world, using today's methods, it undermines the trust in public health, which can cascades down to how healthy our communities are. We are committed to keeping, investing, and trying for a new approach to public health, one that is seamless across jurisdictions, responsive to reality, and supporting the public that we serve. A system that works closely with community and so that they're healthy, safe, and vibrant. Imagine how healthy Minnesota could be if Minnesota could better prevent health problems before they start by changing policies, systems, and surroundings that impact health. Together, local health directors, state health officials, and locally elected community health board officials are guiding this transformation. And this is something that really excites me and is important that we are leading this charge together. And why we're committed and why we're working together, there are certainly a number of challenges that stand in our way. Our system has obviously some strengths as that we are locally driven, right? Each department can work on unique and distinct priorities with their community. However, the ability of these health departments to do foundational public health work varies widely, leaving a patchwork of public health coverage. And that is really confusing to the folks we work with, whether they're community organizations, businesses, hospitals, et cetera. They don't know what to expect from one health department to another. And while the counties you see on the screen here have unique issues and their approach to statewide issues might look very different, they all must have the basic capacity to work with communities to identify and implement shared solutions. When our system was created in 1976, it was seen as forward-looking, and it was a model that other states followed. Even today, we are widely known for our strong partnership between state and local public health. But 50 years later, our system still struggles to meet our problems, and our outdated approach undermines our ability to work with community to enact proven effective interventions that address root causes of health issues while reflecting local needs and priorities. Our current approach makes it easier for health departments to deliver services to individual people one by one instead of capitalizing on public health workers' expertise and experience to diagnose community health, cooperate across sectors, and prevent illness before it starts. On the screen, you'll just see one snapshot of data from 2023. This data is about health departments' ability to use data for decision-making, share that data with the communities and elected officials they work with. And you'll see here, not only are we missing the mark as a system, but also our smaller health departments are less able to fill this important role. And you'll see this across lots of data in the report. We, as public health workforce, are committed. And you'll see in national and state surveys that people come to this work because they care about and are passionate for the communities that they serve. But we would say they are a small and mighty workforce. There is not enough passion and commitment to get all the work done that's needed. And that's a complicated issue, of course. And one aspect of that is local health departments struggling to create new positions, fill new positions, and grow those skills. And underneath that is a couple of issues. One, enough funding to fill those positions, but also funding that isn't restricted to certain tasks. And in some cases, a willingness to hire or contract for staff on time-limited, restricted funds. This data is pre-COVID, but certainly the issue persists and is even worse. Public health has proven whether it's working with transportation to create safe places for people to be active or working with businesses to bring healthy foods into communities without access, that we can work across sectors and that we can focus on prevention to the community's benefit. But all too frequently, what public health works on and who they work with is dedicated or is limited by prescriptive, time-limited funding. When compared with spending on healthcare and medical care, the share of public health spending is very small. I know we've shared this data before. Public health spending routinely makes up less than 1% of the total money spent on healthcare and public health, and its growth is much slower than the overall total. Our health, as we know, is more than individual care and clinical care. Before we eat healthy food, that food has to be available and affordable. Before we buckle up in the car, the manufacturer needs to install the seatbelt, and we need to know that the other folks on the road aren't distracted or impaired. What if government invested in prevention through public health and changes to the policy systems and surroundings that shape health of entire communities instead of paying for individual medical care after someone got sick? And you can see here it's not a hyperbole to say that an ounce of prevention is worth a pound of cure. Public health and prevention do provide good return on investment and make sense for the entire state. Again, we'd love you to imagine how we could be better if we could prevent health problems before they started. And I assure you that we are doing more than imagining, which is why I have my colleague Nick here to talk about the path forward.
Welcome to the committee, and please state your name for the record and begin.
Good morning. My name is Nick Kelly. I'm the Public Health Administrator for the City of Bloomington, and I'm here in my role as the past chair of the Local Public Health Association in 2024. Part of what we wanted to acknowledge is thanking this body for the investment that was made in public health. Minnesota became one of the few states to invest in their public health system, and we are seeing the dividends of that. We saw this investment in 2021 with an increase in the local public health grant, and again in 2023 with additional funding for foundational public health, for response sustainability grant, and more recently with some additional funding for cannabis work. This is dramatically impacting how we can provide local public health service and the largest investment in the local public health infrastructure since the 70s. What we're realizing, though, is as we navigate this 21st century, our tools and processes continue to change, and a lot of our systems, as Chelsea already highlighted, are antiquated and a challenge. One of the investments the state made was allowing us to do some innovation and figure out best ways forward. We've worked on developing tools and processes for doing that to meet these 21st century needs. This is a quote from a local public health director about dreaming of something, and in this case, this person was talking about something they've been dreaming about their entire career in public health, and with an investment the state of Minnesota made, that became a reality this past year. These 21st century tools are grounded in how we work in the community. We have access now to some data tools and processes that are the first in the nation. Here in the Twin Cities Metro, there was a pilot for the health trends across community, pulling electronic health records for 90% of the state of Minnesota, something that's never been done across the U.S. And so staff from that were presenting at CDC and other entities showing the incredible innovation an investment in Minnesota made in this system to allow us to change how we think about health data. Similarly, we see things in the excuse me, the southeast portion of the state, where Olmsted County is leading an effort to change the way they work across multiple public health jurisdictions, centering some of that expertise and availability, showing some genomic surveillance and data systems that many agencies had never had access to before. And we also see incredible stories of communication and building capacity with this innovation fund across the entire state. Partnership for Health, we see amazing works in Hubbard and Beltrami, we see Clay and Ottertail, incredible stories of a little investment changing the way they can communicate and interact with their community. It's incredible to see that work. This is an example of a quote from a trusted messenger program that was done here in St. Paul Ramsey County, where really centering how we work to convey health messages from community partners we're seeing a dramatic change in whether it's working with TB to measles to other chronic or infectious disease issues. Having somebody that looks like you, speaks your language, and navigates the same cultural realities that you do, communicate health information in a way that you understand is profound. Much like this image you see, you can't plan on harvesting a crop without doing a lot of work to prepare the soil, to plant and grow. And what we see is the need for that sustained investment in public health. We need to foster that right size solution for providing public health services in Minnesota. We need to be focused on that local delivery with this incredible resource we have with our state partners. And this panic neglect cycle, we often talk about it being this boom or bust. Bad thing happens, we provide a bunch of funding for resources, those resources dry up, the ability to manage the bad thing that happened disappears, and we lose a cadre of public health workforce, and we go through these cycles. I've been in this field for enough time to see 2 of those cycles happen, and the challenge of watching many public health practitioners leave the field and programs and processes designed to prevent future challenges disappear, and then seeing the consequences of that de-investment down the road. Commissioner Maltier would also like to be here, and if you know her, you love her analogies talking about her experience as a farmer. Her reality of this is just like being a farmer, we can't navigate this work without preparing the community, the environment, and sustaining that investment. And that reality is if we don't do that, our community's health will suffer. So as we said, we continue to find those innovation and new approaches with that small and investment in infrastructure here in Minnesota. And those alternative, changing, tweaking ideas have been really transformative. Some of those examples we're now seeing replicated across the state. The way people are doing communication and leadership, the way people are working with data, it is doing what was intended with this innovation fund. It's finding new models and processes and making those happen across the state. You can see we've seen those innovations occur across the state. We have projects that are ongoing, we have projects that are new, and we have projects that are completed and we've learned and processed and grown as a public health agency. I would encourage you to look into some of the details about that. You'll see them in the report, and they're also on MDH's website. There is a lot of incredible innovation occurring. One of the opportunities we see with that is this is feedback from one of those data innovation projects of being able to actually think, process, and use data in ways we've never had before, allowed them to be able to pivot and adjust to respond to challenges in their community almost immediately. Something that public health has not really been able to do with data. Sometimes our data is a few years old or months old, and now we're able to see it more real time, which is incredible. So this is where we're going. We are focused on this continued partnership. We have an incredible partnership with our state of Minnesota, the Minnesota Department of Health, incredible partnership with SHAC, the elected leaders advising the state on how to move public health forward. We're building that partnership with our tribal partners. That has been an incredible journey to watch from the joint leadership team helping drive some of this work. We're continuing to look for that investment. Public health is a core government purpose. And so there is a shared responsibility between our federal, state, and local partners, and we continuously look at how do you balance who does what and how do you do that. You cannot have that thriving, incredible state without healthy people. And so that is a key role that we drive to make happen.
Thank you. Thank you very much for this presentation. And members, you do have the full report in your packet if you want to reference some of the projects or the text that was provided in the presentation. Senator Gruenhagen.
Well, thank you, Madam Chair. Yeah, thanks for your presentation. You know, I'm going to just throw out an idea here. You know, on page 16, you said funding is prescriptive and time-limited, inflexible, and often addresses individual services and not scaled during emergencies. Well, I think that's a pretty good summary, to tell you the truth. And I think we need to think of the idea of block granting money down to the counties and with guidance, not mandates, and allow them to meet the needs of their constituents, which they care more about, in my opinion, than what we do. And that doesn't mean you don't have some audit teams to check on them. But if you did that, you would have all these 87 counties would be able to experiment with what works best in their area, and we could learn from each other. The problem with the government, state government and federal, is they come up with one-size-fits-all mandates for everybody, and a lot of it doesn't fit, okay? It's expensive. And again, the bureaucracy of is causing more problems than it's actually solving. Now, again, I got 4 or 5 counties in my district, and whenever I go to these county commissioner meetings and the HHS director speaks, they all say the same thing. We cannot get to the people to fill out the forms that we have to that are receiving benefits across the board. And now I know that time's been increased to I think a year, where it was much shorter before. But they all say the same. They say, if we had the flexibility, we know people who are paraplegics who are confined to a home. We don't have to check them again. The other thing, the mandate of the questions that you have to ask these people is just doesn't apply. In fact, I got that message from at least 3 out of the 4 HHS agency heads that I talked to in my counties. In fact, they said in some cases, people will say, well, why are you asking me that question? So again, I think when we look at the problems that we have here, one of the things we need to do is look in the mirror, okay? And I'm not saying these aren't well-intended regulations and mandates, but in the end, you'd be better off trusting local counties, doing a little checkup on them, you know, audit teams, and then allowing them to experiment to meet the needs of their constituents or their citizens, which they will do, in my opinion, much more effectively than what we're doing here. Again, appreciate your presentation. I know you're well-meaning, but this one-size-fits-all mandate does not work. You're causing more problems than what you're creating. So I'm just throwing that out to the committee. It's a major change, but we need to start trusting our local officials on these issues. Otherwise, we're going to collapse under the weight of our own bureaucracy. Thank you.
Thank you. Ms. Huntley, if you'd like to talk about that. And we didn't talk about it very much in the overview of the Department of Health, but maybe highlighting like how much of the funding comes from the federal government and maybe how that is directed to specific grant programs. But Ms. Huntley.
Yeah, Chair, members of the committee, thank you for the question. I will get back to you on how much is passed through and where it comes from, for sure. And yes, we absolutely have been successful at the Department of Health with your support to put out a local public health grant and funds that are not restricted. And that's something we want to continue to do. Thank you.
I think in the report, it talks about some of the federal grants are more
Yes.
narrowly focused too, and maybe we don't have influence over that, but that I think is another concern. Senator Gruenhagen.
Yeah, I know there'd be speed bumps to do what I'm talking about. But, you know, the nice thing is, with the new administration, you could apply for waivers at the federal level from those requirements. And once you receive them, which I think they'd be open to at this particular point, you would have the flexibility to do some block granting. Those are my thoughts.
Thank you. Other members, do you have questions or comments? Senator Liskey.
Thank you, Madam Chair. Madam Chair, Commissioner, I guess a good question is I'm seeing a lot of basically a big ask on this. We're asking about improving to 21st century tools. The big question is it kind of counteracts the discussion of how do we make healthcare more affordable if we keep adding to it, adding to the cost. How is this going to reduce the cost overall?
Ms. Huntley, or, yeah, go ahead.
Yes, Chair, members of the committee, thank you. I think what we're asking is that we shift or we invest more in prevention. We don't want to add more cost to healthcare. We want to help folks by changing the surroundings in communities before they get sick, before they go to the hospital.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, it's kind of interesting that that's where you guys are at. Being that I read through the budget, the budget that we were proposed from the governor's office, there was a lot of preventative health care measures that were being cut from Medicaid spending. So under that, I don't think the communication is making much sense. I'm seeing a lot of disagreeing positions. I agree that we should be focused on prevention. In fact, that's one of the things that I talk about. If we can prevent things, it changes the cost drastically. But I'm not seeing that as part of the budget proposals that I'm seeing now. So that's why I'm asking.
Thank you. Other members? Senator Hoffman.
Thank you, Madam Chair. And it's a more of a get to the essence of the report. And there's a couple of we knows. We know that the National Institutes of Health in 2023 established disability as a health disparity. So I guess first question is help me understand how that's being intertwined in all the work you're doing. And then the second question, which you can just, it's a conversation dialogue, is one of the 10 priorities that the state has under its Title V response to Health Resources Service Administration is the adolescent suicide piece. And so can you help me understand how you're engaging that outcome, that Title V outcome that you're trying to get to, and how that is being, and that same question then also goes to 33% of the funds in any activities are supposed to be for children and youth with special health care needs. So can you kind of give me a brief overview of how the state is doing those? Was that enough questions in one sentence for you?
So we want to talk from a local level or no?
Mr. Kelly or Ms. Huntley?
Madam Chair, Senator, on the disparity end, the way we often think about that is purely from you have your standard population and you have a difference. And so we see that often where the disability community shows up with a much higher rate of many other health conditions or challenges. And so managing to overcome those is part of that charge that we have at the local level of figuring out how to do that. It makes no sense for us at the locals to do something and to have it not be accessible to everybody. I think our curb cuts are a great example of that. That is a requirement and an expectation, but it makes it a whole lot easier for me to push a stroller, just like it makes somebody else to use a walker to get around, and it makes our community better. The reality for us is on the suicide prevention work, that is part of our community health assessment. We see that across the entire state of Minnesota, that almost every local health department is working on some aspect of mental health and suicide prevention because of the concerning data we see out of our schools and our youth, and that's what our community tells us. So we're doing that work. Title V is helping, but we're doing that work because that's the community need. That's where we're aligning the the foundational and other investments the state is making to allow us to do that work.
Senator Hoffman.
So, Madam Chair, it's nice to hear that local piece of it. Title V whole purpose was to get a coordinated, collaborative, and comprehensive approach to public health. Senator Avery didn't hear the 3 C's on that one, but that's I did the three C's, Jim, just to let you know. That was funny. But to that point, I'm still not seeing it embedded in the reporting, and maybe that's just because I'm looking at it from a lens of that 33%, and so it would be nice. Thank you to hear from the local public health perspective, because that's where it matters, right? It would just be nice to see the department kind of, expand on that a little bit, and that's just, again, my own personal opinion. So thank you.
Ms. Huntley, did you want to comment? Or?
Madam Chair, Senator, thank you. I am not the person to speak to Title V today, and we can certainly get back to that. Wasn't part of this report, but thank you for the comment.
Madam Chair, let me just, Title V isn't just a standalone. That's the thing that, like Part C in early intervention services is not just a standalone. It's supposed to be a systemic approach to how we do our business. So that's just an interesting response, Madam Chair. And with that, I'll say thank you.
Thank you. Senator Grunhagen.
Senator Hoffman's, thank you, Madam Chair. Senator Hoffman's comments made me think of an issue. Yeah, I was on the school board for 16 years, and one of the things was the suicide prevention. And I think when you look at that, look at the curriculum we're teaching the children, because when you look at the curriculum, or even the social media, the AMA in the 90s, when I was on the school board, I started on the school board, came out with a report that some of the suicide prevention programs were actually making children susceptible to suicide. And I've got actual examples of curriculum that were used in the 6th and I think the 5th grade that children could decide on some terrible results rather than being told what the right results are. So take a look at the curriculum, make sure it's documented to actually prevent suicide rather than promote it. Thank you.
Okay, thank you very much for your presentation. And then if members have other questions, I'm sure they can get in contact with you to ask about more details. So thank you again.
Thank you.
And now, now we'll move to a presentation about status and planning update on H5N1. And I show on our agenda, Stacy Holzbauer is here from the Department of Health. Welcome to the committee, and please state your name and title for the record.
Thank you, Madam Chair, Senators.
And make sure you have the microphone close and speak right into it. So okay. Thank you.
Thank you. Good morning. My name is Stacy Holzbauer, and I'm the State Public Health Veterinarian at the Minnesota Department of Health. Influenza is alphabet soup. There are 4 types of influenza viruses: influenza A, influenza B, influenza C, and influenza D. And each has its own unique reservoir species and epidemiology. Influenza B, C, and D have a limited host range. Influenza A viruses circulate widely in humans, wild birds, domestic birds, swine, horses, dogs, and bats, and cause seasonal and sporadic epidemics in humans, birds, and swine. Occasional infections have occurred in marine mammals, ostriches, pandas, and other animals. Influenza A viruses are maintained in migrating waterfowl and transferred around the globe with each migration. These viruses are constantly changing and swapping genetic material. So while each species tends to have a specific influenza A virus that are easily transmitted either from person to person or animal to animal, influenza A viruses can share genes that then lead to new viruses that cross species. H5N1 is primarily an influenza A virus of wild birds that has shown a unique ability to cause illness in multiple avian and mammalian species. H5N1 highly pathogenic avian influenza viruses arrived in the U.S. via migratory waterfowl in 2022, and it has had devastating consequences on domestic poultry. In Minnesota, 182 poultry cases or flocks have been affected, including 142 commercial operations and 40 backyard flocks that have been depopulated. There have also been 10 detections in livestock, with 1 positive goat herd and 9 positive dairy cattle herds and 5 positive cats. Nationally, over 1,400 confirmed poultry farms, 928 dairy herds, and 74 domestic cats have been reported. This has all led to millions of dollars in losses to farmers, increased food prices, and deaths of beloved pets. This virus has also been devastating to wild mammals, with many outbreaks reported worldwide, including in farmed mink in Spain, farmed foxes in Finland, sea lions in Peru, Argentina, and Chile, and elephant seals in Argentina. Since its introduction into the United States in 2022, the virus has expanded its host range and has been detected in 27 mammalian species. H5N1 is still primarily an animal disease. However, these viruses can be spread to people through direct contact with infected animals or their environments. Person-to-person spread is rare and limited overall and has not been detected in the United States. This virus is currently a low risk to the general public. Rather, the risk is primarily an occupational risk to those people who have direct contact with infected animals or their environment. To date, there have been 67 people with confirmed H5N1 infections in the United States. None of these have been in Minnesota thus far. Most infections have been mild, with conjunctivitis or eye infection as the most common reported symptom. 23 human cases have been associated with known positive poultry farms. 1 person with underlying conditions had exposure to an infected backyard poultry and then developed severe respiratory disease and unfortunately passed away. This has been the only death among human cases in the U.S. thus far. 40 cases have been associated with positive dairy cattle herds, and 3 have been detected through routine human influenza surveillance, and their exposures are unknown. While most of these rare human infections have been mild, our biggest concern is that someone will be co-infected with a human seasonal influenza virus and an avian influenza virus. And the genetic material of these viruses will go through a process called reassortment, creating a new influenza virus that could be easily transmitted from person to person. That is why it's critical that we take a One Health approach, working across multiple sectors to monitor people for H5N1 viruses in animals and people. Minnesota is unique in that we truly take a One Health approach to H5N1. 3 state agencies, the Minnesota Board of Animal Health, the Minnesota Department of Agriculture, and the Minnesota Department of Health, and numerous other partners are working closely together on this response. MDH is integrated into the animal response as human disease surveillance officers and receives information in real time. We enroll exposed people and responders in human disease monitoring and provide prevention recommendations and public health information to animal health partners, animal industries, clinicians, and the public. As part of our response, we have monitored the health of agricultural workers and others who have been in direct contact with infected animals in collaboration with the Board of Animal Health, Department of Agriculture since 2022. To date, more than 2,400 people have been monitored. We have coordinated testing for H5 viruses among exposed people when needed and facilitate influenza antiviral treatment when indicated. We have collaborated with local clinics and local public health agencies to provide these services. We encourage the use of people's own clinicians when possible, but we have standing orders available for antivirals if people have no alternatives, and we have a small supply of oseltamivir if needed. At the same time, we monitor established routine human influenza and wastewater surveillance for potential detections of H5 viruses. MDH constantly communicates and coordinates our response efforts with our federal and jurisdictional health partners. We also communicate, educate, and coordinate with clinicians, local public health, tribal health, dairy and poultry industries, and veterinarians. We provide education on the latest human health developments to agricultural and community-based and migrant worker organizations, including working with our University of Minnesota Agriculture Extension. And we have worked with our federal partners to provide personal protective equipment, or PPE, to affected agricultural industries. For people who are exposed to affected animals, the PPE recommendations are extensive. Coveralls, boots, gloves, goggles, and 95 respirators should be worn in farm environments, but these environments are often dusty, wet, and hot. Therefore, compliance is generally low. Exposed individuals are monitored for 10 days after their last exposure to a positive animal. Testing and antiviral prophylaxis are offered as needed. H5N1 is a challenging pathogen. It's currently causing rare and mild illness in agricultural workers who are challenging pathogen. It's currently causing rare and mild illness in agricultural workers who are primarily young, healthy, and male. These workers work on 24/7 operations and often have limited literacy and English proficiency and have systemic barriers to health services. The PPE that's available is medical grade and often cannot hold up to the demands of the job. And while we recommend seasonal influenza vaccines to everyone, that vaccine does not offer protection to H5N1. However, it may help decrease the chance of someone being dually infected with the seasonal influenza A and an H5 virus. Ongoing communication is key, and we have multiple primary audiences to which we communicate our health messages, including those involved in the dairy and poultry industries, other people who could contact potentially infected animals, agricultural tourism professionals, local public health agencies, and healthcare providers. We apply a One Health approach and collaborate with the Minnesota Department of Agriculture and the Board of Animal Health on consistent messages when responding to news media and producing communication products for the public. We work with local community partners, clinics, and agencies to deliver tailored, multilingual messages to people in contact with potentially impacted animals and promote personal protective equipment and seasonal flu vaccinations using multiple media modalities. We've tried to meet the agricultural workforce by working both through industry and community-based organizations. For example, we've worked with local public health during the fall and winter of 2024 to promote seasonal influenza vaccines among farm workers in rural areas and successfully sponsored 8 vaccination clinics with 250 people receiving influenza vaccines. These collaborations are ongoing. Planning is also underway should H5 vaccine be needed. We are reviewing the lessons learned from COVID-19 vaccination clinics. 2 doses will be needed for robust immunity. There are currently 5 million doses of H5 vaccine in the federal stockpile. Another 10 million doses are expected to be produced by spring, with an estimated capacity to produce 100 million doses in a 5-month span. Work is also being done to develop mRNA vaccines. We are working closely with federal government agencies in this response. We will be receiving federal funds through Crisis Response Cooperative Agreement this month to further augment human influenza surveillance system and strengthen the pipelines to increase the number of isolates with subtyping data from hospitalized and outpatient influenza A cases. We are also working to increase our outreach to populations most at risk, strengthen our One Health partnerships, and further coordinate efforts, and provide PPE to affected industries, and continue to update guidelines and maximize stockpiles of vaccines and antivirals. Next one. Sorry. Oh. And with that, I'm happy to take any questions.
Okay. Thank you. Thank you very much. Members, do you have any questions about this presentation? No? Okay. No, I just, if you have a question, this is one, presentation we wanted to make sure that from our committee standpoint, we knew what the Department of Health was working on, and we realized that it's coordinated with the other agencies, and just wanted to make sure if there were questions at this time about the department's response, that you'd have this information. So, Senator Gruenhagen.
Oh, thank you, Madam Chair. Yeah, thank you, Commissioners. Say, just one question on the vaccine. One of the concerns I hear from my constituents is they'd like to know the ingredients that are in a vaccine before administering them to themselves or their children. Has there been any work? Is there a disclosure on vaccines, any type of mandate, so people actually see what's in a vaccine?
And Ms. Holzbauer, I don't know if that's an area that you can provide the information on, or if there's anybody else from the department who.
Thank you, Madam Chair and Senator. So my role as the state public health veterinarian is working on those One Health relationships with our industry, and I don't know if any of my vaccine preventable diseases colleagues, we can circle back to get you that information.
Thank you. Appreciate it. Appreciate a response.
Okay. Thank you. Any other questions? No? All right. Well, thank you very much for coming today and presenting. And next we will move to a different topic. We'll move to a presentation on the 340B covered entity report. This report came out in, November. And we wanted to make sure that we had a chance for the committee. We know that pharmacy-related topics are of interest to this committee. We've had discussions the past 2 sessions about ways to impact and assist community pharmacies, and discussions about that aspect of our healthcare system. And so we thought that a presentation on this report, because it is a nation-leading, unique report that hasn't been done in the past, and we will be seeing it annually. We wanted to get started on understanding what the report tells us and kind of what it doesn't tell us. And today we have Stefan Gildemeister here, who is from the Department of Health. Welcome to the committee, and please state your name for the record and begin your testimony.
Good morning, Madam Chair, members of the committee. For the record, my name is Stefan Gildemeister. I direct the health economics program, and I'm the state health economist. And thank you for having me here. I know healthcare financing can be pretty scary too, but I hope it's not as scary as the notion of 2 influenza viruses combining, but we'll see. Just maybe a quick word about the health economics program. Our role in state government is to monitor changes in the healthcare market and help you and the public understand factors that influence healthcare costs, quality, and access. We look at the healthcare market, and then you see our work through reports, issue briefs, data dashboards, and presentations like today. You've asked me to talk about the 340B report that we issued late last year, and here are the 4 things I'd like to cover. I'll provide you a little bit background on a complex and poorly understood program that is actually a federal program. I'll cue up how we ended up with the report by referencing the policy discussions in 2023, show you some findings, and then conclude. Be happy to answer questions after that. The federal 340B drug pricing program was established in the early 1990s, and it was sort of an accidental result. Well, I think the experts are still debating how this program came to be, but I think many seem to agree it was an accidental result, or rather a result of high prescription drug prices, where the federal government or Congress decided it would cost the Medicaid program too much money, so they established a Medicaid drug rebate program, which lowered the cost for prescription drug for Medicaid programs. And then safety net hospitals sort of argued that they faced high challenges as well due to the high drug cost. So Congress passed the 340B program as a mechanism under which covered entities, these are generally provider organizations, I'll say more about that, can acquire out. And the program particularly well described, other than that its intention is to bring more resources to the provision of safety services in provider settings. And healthcare providers, if they provide drugs free of charge or with a rebate, can use these resources generated under the program to offset their uncompensated care cost, or use the revenue generated from the program to deploy within their institutions. And I'll say more about that. I know it's a little abstract still. As I said, the program lacks transparency, and it also lacks some clear articulated expectations of how the program ought to be implemented. It's grown significantly, and because of that, there are some pretty intense passions about the program among manufacturers who are concerned that they're providing discounts by intermediaries who are benefiting from the program, including pharmacies and PBMs, and provider organizations who have become accustomed to the benefits of the program. Like everything in healthcare, it really interacts pretty intensely with other dynamics in the market, which makes it really difficult to understand and to assess how it's working. How did we end up with the report? Policymakers in 20 and 23, you discussed alternative ways of delivering the Medicaid prescription drug benefit. One idea was to carve it out and let the Department of Human Service manage it. But medical systems at the time were concerned that in the process they would lose revenue that are part of their ongoing operations. But detailed and transparent information on revenue that was at stake if the Medicaid prescription drug benefit was operationally changed was not available. So you passed a bill requiring the Department of Health to collect data on the volume of revenue distribution across payers, look at specific drugs, and help you understand the differences amongst covered entities. Just quickly on process, the law requires MDH to collect data by April of a given year and provide a legislative report in November. As Madam Chair, you said, this is a national first. A lot of excitement about Minnesota leaning in and trying to bring transparency to a program that has so much passion associated with it, and bring actual evidence to policymakers. Our report, as required, focuses on overall 340B revenue, and we're looking at entity type, payer type, and drug product specific information. The report does not look at how the 340B revenue is used by individual provider organization. It was not part of the requirement. We've also not been able, not looked at the impact on patients or entities in particular. 24, you passed technical amendments to strengthen some of the definitions in the law, and in some ways this work is an ongoing initiative by the legislature to bring more transparency to a very complex prescription drug market affecting all of us. So I'll walk through some of the findings in the next few minutes. And I apologize, I don't have nice pictures like my colleagues coming before me. My presentation is tables and graphs and text, but I hope that's okay. Roughly speaking, there are two groups of covered entities in Minnesota and under the program. They consist of hospitals. These are nonprofit hospitals that meet a set of requirements under the federal law, and then a set of clinics that either are safety net federal grantees or serve certain population groups like patients with TB. First data column shows you the number of entities that we understand exist in Minnesota. The second column shows you the reporting by those entities, and the third reflect the number of entities whose data we felt we could include in the report because the quality was relatively high. For first-year report, I think we're really pleased by the partnership with provider organizations and the data that came through. The entities whose data we ended up not using tend to be small entities and should not affect the directional results of the program. So again, 340B is about giving provider organization the ability to obtain drugs at a steeply discounted level and then to bill market rates typically to other providers, although not all provider organizations do that. How does that look in Minnesota? In aggregate, 340B entities, covered entities in Minnesota, spent about $850 million purchasing 340B drugs and paying for operational aspects of these drugs. So that is split between $734 million in acquisition costs and $120 million payments to contract pharmacies and third-party administrators that help these entities manage their operations. And then the 340B covered entities then received reimbursement or payments for these drugs in the amount of $1.5 billion. So if you do the math real quick, and I hope we did it right, the net revenue of these drugs $1 billion. So if you do the math real quick, and I hope we did it right, the net revenue across the overall program is about $630 million that flows into 340B organization. There's some variability among entities. Not every entity generates positive revenue. As I said, some reduce their operational cost, but in aggregate, this is what the picture looks like. I wanted to draw your attention, though, to an important aspect of these first-year findings. Most covered entities did not report so-called drugs, office-administered drugs, revenues associated with drugs that are administered when a patient comes to the office, whether these are infusions or such drugs. These tend to be very expensive, high-cost drugs, and therefore the estimates that we're providing in this first report are pretty underestimated. They could represent about half or even 1/3 of the actual revenue this program generates for Minnesota entities. So I would say stay tuned for the next report when we implement data collection in a more precise manner, requiring the movement of data by reporting entities that is more comprehensive.
I think there are a couple questions that could be asked right now. Senator Gruenhagen got my attention first, and then I'll go to you, Senator Rasmussen.
Well, thank you, Madam Chair. You know, one of the ways to not have ask so many questions is quit talking about things I have a strong opinion about, okay? Just for the record. You know, members, and thanks for your report. I assume PBMs are involved in this process, even with Medicaid patients, is that correct?
Mr. Gildemeister.
Madam Chair, Senator Gruenhagen, a good assumption, although in an indirect way. PBMs don't really play a direct role in the transaction, but PBMs own pharmacies, and therefore they have an interest in engaging in the 340B program, increasing it because they generate more finances.
Senator Grunhagen.
Oh, thank you. Thank you for that response. Yeah, just, I've been involved with a number of independent pharmacies that are barely hanging on in my district, and we're social engineering them out of business. I give additional. And in fact, I participated in a protest at a PBM here in the metro area. And anywhere PBMs are close to a particular government program, or even commercially, I find a lot of corruption. Okay, the more I learn, the more corruption there is. So that's just things that we should look at reforming. The other thing I would state is Mary Krinke and Danny Eckert just handed us a letter, and here's what they say about your report. They say that the MDH's report lacks critical context on the purpose and impact of 340B and its 30-year status as an essential benefit program. By adopting Big Pharma's industry-preferred definitions and metrics, the report presents an incomplete and potentially misleading view of a program that exists solely to support safety net providers and protect health care access for Minnesota's patients, vulnerable patients. And again, I'd encourage everybody to read the report, but on the back page of the first page, it says the MDA report leaves out necessary context on the 340B. Do you have any response to those allegations?
Mr. Gildemeister.
Madam Chair, Senator Greenhagen, as I said, this issue generates a lot of passion because it's a lot of revenue moving through the system. I think the team has done an incredible job and a nation-leading job in producing this report. So I'm pretty proud of the work that we did. I don't believe it lacks context because the report is intensely detailed on the history of the program, the controversies about the program, and sort of by definition, we do what the legislature asks us to do. We focus on the data that the statute requires us to report. Yes, Big Pharma, and I think this refers to manufacturers, are pretty irritated about the program because they are required to provide discounts. So either they lose revenue or they have to build the discount into their overall pricing. The manufacturers have actively argued against the 340B program. This report is describing the program. It's neither for nor against it. And then I think I would go back to, I think the last point was the wrong metrics. Again, I would say what we have tried to do is what the statute requires us to do. And the metrics are the volume of 340B revenue, looking at these revenues across payers, and looking at prescription drugs. So I think that would be my reaction.
Small comment.
Senator Greenhagen.
Yeah, well, thanks for that response. And, I have a lot of concerns about PBMs, especially because they tend to control the formulary. They keep the rebates and put drugs on there that they get the biggest rebates from rather than what's most effective or cost effective. Those rebates should be passed on to the consumer to lower the price of drugs. Instead, they're pocketing them, making millions. And so there's a whole host of problems with the PBMs from what I've learned. So the other thing, Madam Chair, I would sure appreciate that when we have a presentation like this, that it would be nice to hear a contrasting view from the Minnesota Hospital Association rather than this letter, so that the public could actually hear their concerns about this report in the future. It's one of the ways we both learn. Thank you, Madam Chair.
Thank you. Senator Rasmussen.
Thank you, Madam Chair. I just had a question for the director on this page specifically. So if I'm understanding it correctly, this analysis is showing that there was $630 million in net revenue in 2023 for 340B entities through this program. But what you're saying is that this is likely only capturing a half to a third of the actual 340B net revenue. So I just want to make sure my understanding is correct. You're saying it's about $1.2 billion to $1.9 billion per year in net revenue going to these entities? I just want to make sure I'm following the math.
Mr. Gildemeister?
Madam Chair, Senator Rasmussen, you have it right. The reason these numbers are understated is because the drugs that are not included for most entities are, as I said, high-cost drugs. And if you have a high-cost drug, a high discount is a large number. When we estimate that this is an undercount by about half, our sense, it's not entirely a conjecture, but I would hesitate to name an actual number. Our sense is, based on data that we've seen in the national context, that it could be as little as a third. But I would say by November this year, we should have a more firm number. I should also add that in many ways, this is a $66 billion program. And at the national level, what we're understanding about it, what we know about it, and as I said, even at a national level, there's not a lot of transparency. The dynamics, the data that's become available to some analysts is kind of consistent with what we're thinking at the moment.
Thanks. And if you can proceed, we do have kind of a constraint of, finishing at 10:30, and I do want to make sure we get to you've got takeaways and considerations about the information, so I want to make sure we get to that at the end. So please continue.
Thanks, Madam Chair. I'll speed it up a little bit. This visual gives you a sense of where, how the 340B revenue, the net revenue distributed across on the left side, the type of covered entities, and the right side, the payer type. And really to summarize, and none of this is probably surprising to you, most of the revenue is associated with hospital organizations because they're large, they have a significant number of fills, and they also prescribe high-cost drugs. On the right-hand side, I have to admit that our team was a little surprised with the motivation for the report being the focus on Minnesota healthcare programs. We realized that just accounts for 14% of the revenue. Most of the revenue indeed seems to be coming through the commercial market and the Medicare Advantage space, where covered entity patients get a script, the entity receives a discount, but then bills the managed care organizations or the insurer a market rate, allowing for this for the gap as noted here, or for the volume, for the share of overall 340B spending of about 343 plus 197 million. I think I'll skip this chart other than to maybe quickly, in the interest of time, other than to sort of make that point again that the volume of 340B revenue flowing through types of payers is to an extent dependent on the size of the organizations that submit them, but also the type of drugs that are being prescribed. So on the right-hand side, you see a column of average net 340B revenue per drug fill, and in the commercial and Medicare program, these revenues are significantly higher because of the high-cost drugs flowing through Medicare and through the commercial program. When I started out, I sort of indicated that one of the interest was to look at the extent to which there are different experiences across covered entities. As I indicated, these organizations serve different patients and are different sizes, and I think that's to an extent reflected in this display on the left-hand side. So you have the number of drug fills. These are distributions. They add to 100%. And on the right-hand side, you have the distribution of net revenue. So quickly to pick up 2 points, general acute care hospitals account for about 60% of fills, but 80% of 340B revenue. And on the other extreme, the safety net grantee clinics account for 7% of fills, but only 1% of the net revenue. As part of the report in an appendix, as required, we identify the top 26 facilities that account for about 90% of 340B revenue as reported to us. I will not say more about that. One of the items of interest, though, and one of the many unanswered questions for us, is that it indicates the percent of the 340B revenue that is due to Minnesota healthcare programs, or rather patients who are prescribed drugs under the 340B revenue that are eligible for one of the Minnesota healthcare programs. And there's a real distribution where some hospitals or health systems don't take advantage of it, but others do, and it's not entirely clear to us why that is. One of the really remarkable aspects of the statute and the report is that we actually had the chance to look at drugs prescribed under that program and to what extent these drugs account for a portion of 340B revenue. And this, to an extent, overlaps with Senator Gruenhagen's concern about PBMs. How is the movement, what are the incentives that drive the systems? To what extent are prices established by manufacturers and then renegotiated by PBMs affecting the 340B program? So we looked at the 50 dispensed, most dispensed drugs from 340B hospitals. They accounted for about 1 million prescription fills, or about a quarter of total 340B drug fills in the state. And the top 17 drugs or drug families accounted for 6% of fills, but 70% of drug level 340B revenue. And many of these are the kind of drugs that you read in the newspaper about that are in high demand, but also very expensive. These are the type of specialty drugs like Ozempic, Wegovy, Trikafta, Humira. And Humira alone accounts for 13% of the overall 340B net revenue that we've reported on. Madam Chair, my last slide. You know, our takeaways, and again, other people may have different perspectives on this, but from the team at the health department and our partners at the university, we find substantial net revenue for Minnesota covered entities from the 340B program, but also variability between covered entities. As we've discussed, because of some missing data in the first round of the report, these estimates are underestimates, and so we want to come back to them, and we feel in aggregate these numbers align with what we know from national reporting. But there are so many interesting, curious, complex questions that this report didn't go to because the report was focused on the facts that I presented. So questions such as how do providers use net revenue, and how does it relate to healthcare financing more broadly? To what extent do 340B revenues flow through patients? Is that direct or less direct? What's the interaction between program expansion and the price of prescription drugs that we all ultimately bear? Are the incentives aligned? To what extent is the 340B program and the market failures that it's trying to respond creating unintended consequences, and many, many more questions. But I'll pause here, and I'm happy to take your questions.
Thank you very much. Senator Rasmussen.
Thank you, Madam Chair. And I appreciate this report and the ongoing conversation. I think one of the takeaways that I've had today, and as I've learned more about 340B, is that it's a very complicated cross-subsidy in healthcare, and we have lots of cross-subsidies in healthcare, but this ends up being a pretty big one, right? When we look at Minnesota and we're looking at, this is billions of dollars a year, impacting the healthcare system. And one question, Madam Chair, that I had for the director, and I don't know if this could be reviewed in an upcoming report, but one of the questions I have is how much 340B is costing the state. And the question I have around there is, our state Medicaid office also gets rebates for people that are on public programs, but because of the federal prohibition on duplicative discounts, do we understand or could we understand what the cost 340B has to the state general fund budget?
Mr. Gildemeister?
Madam Chair, Senator Rasmussen, a really informed question and a really good one, of course. We have been in close touch with our colleagues at the Department of Human Services, and I think they would wish for them to be the entity to report to you, to respond to your question. But I think it's fair to say there are potential savings to the Medicaid program in structuring 340B differently. But that would come at a cost of revenue that providers currently generate by the program.
Did you have another question?
Yeah, thank you, Madam Chair. Just as a follow-up on that, I think this is a complicated program. There's lots of money involved, billions of dollars a year just here in Minnesota, and I think it's really important for us to understand, especially given our budget forecast, just understanding what impact that has on the general fund here for the state and state Medicaid and the state Medicaid's office ability to get rebates for the drugs that they're purchasing. And so I think as you guys are continuing to work, that's a question that I'm interested in, because I think in all these kinds of cross subsidies, the impact it has on the state budget, the impact it has on commercial insurance and the rates that are being paid. And then, lastly, one other item that I'm curious about as well is the impact it has on the competitive landscape for healthcare organizations in Minnesota, where you have some entities that are able to benefit heavily, hundreds, $100 million plus per year, and then others that are ineligible and left out. And does that lead to, consolidation, other types of financial incentives that are changing our healthcare ecosystem? And so I appreciate this report as a starting point and look forward to digging in more as we look more at this program and its impact on Minnesota.
Thank you. I don't know if you have a quick response or if you want to take that down. Otherwise, I've got 3 other people that have questions, so maybe I'll go to those right now. Senator Abler.
Well, thank you. I just got a comment and then just one question. Every time I hear a report on 340B, I learn something, and probably if I'm here 10 more years, I'll learn something about this program. And Mr. Gildemeister, thanks for digging in. And it's really interesting that having a report is like nation leading, and so I'm glad we have a report. And I think as a first run at a report, this is a good start, but it's just shocking that $66 billion and nobody anywhere else knows what's going on with it. So I appreciate that. And I appreciate the feelings of the hospitals that this shores up a relatively rickety hospital system that we've got. Even some of the safety net hospitals, North Memorial and others, are closing beds in this time. And Madam Chair, I hope that as we go forward, looking at the budgets, if you remember a couple years ago, I tried to move some money to hospitals, and we kept it for other purpose. But I don't think we've done a very good job of looking at the funding of hospitals and those services we intend to support, particularly in the populations that we're serving in our Medicaid universe. So hopefully, I don't mean this would, if this goes away, it's going to be even worse. But, Mr. Gildemeister, I'm happy that you're wondering about what the benefits to the patients are. At the end of all this, keeping a place open is probably a benefit, but and that may be a good enough benefit. But I'm interested in, do some hospitals just, are they now more profitable? And I'm glad you're going to look into that. And they used to have a margin. I remember they used to have 7% or something. I think they're far away off from that. And so just my question, so this was brought to me that the FQHCs feel like they're not treated fairly or a little bit, or can you just comment about what their inclusion is? And is some changes needed, or is that all they get, or thank you.
Mr. Gildemeister?
Madam Chair, Senator Abler, thanks for those questions. And yes, I want to agree with your comment that it's important to carefully think about hospital financing. And Senator Rasmussen said, too, to understand the complex system that we have built, partly in response to one concern over time. It's almost like the public health system. When there's a worry, we make financing available, and then we don't think about it anymore. The hospital market has changed. How we deliver care has changed. The financing system has not kept up with it. So that's definitely an important point that you make. I think the second point is the hospital market is not a single static system. There are haves and there are have-nots, and there are hospitals that are vertically and horizontally consolidated, and their experience will be very different from others, let alone from clinics. As far as FQHCs are concerned, they experience more limits in leveraging the 340B program, partly under Medicaid, because they're prohibited, because they typically don't operate in-house pharmacies. And the in-house pharmacy tends to be the mechanisms through which the Medicaid 340B revenue is generated. There may be other challenges, and FQHC, sort of by their mission, have a smaller share of commercially paid patients. So their financing, again, is entirely different from that of hospitals, even critical access hospitals. I would say I can't do their particular challenges justice, but I think they have talked to us about it quite a bit and probably are, again, the better team to advocate on their behalf, and together with the Department of Human Services about what structures should be changed. It's a give and take, right? On the one hand, if you open up the mechanism to generate more revenue, again, there might be unintended consequences. So you as policymakers and the Department of Human Services as the experts under a federal program need to do that work really carefully.
Madam Chair, and I know we're short of time. I hope we can figure out some way. I mean, as we look at the entities that we're serving, in this is the people who are underserved at high risk with all the health disparities and so on, and it seems like FQHCs target that, as do especially some of the urban hospitals and the greater Minnesota hospitals too. So anyway, thank you. Thank you.
Senator Mann.
Thank you, Madam Chair. Thank you, Mr. Gildemeister, and for your work and the department's work. Is there any theories or ideas as to where that discrepancy between the drug fills and the net revenue comes from?
Mr. Gildemeister.
Madam Chair, Senator Dr. Mann, I think that discrepancy is partly an outcome of the drugs that are being prescribed. So if so we didn't collect a ton of specialty drugs, but nevertheless, I think hospital patients probably are prescribed more brand name drugs, drugs following surgery. So there are a lot of high-cost opioids in our reporting. We can share that with you more detailed, or point you to the section of the report that sort of goes into the drug classes and organizes them by volume, by fills, and by volume of 340B revenue. So there's more information we can share with you. But I think mostly it is the type of drugs that are being prescribed in different settings. FQHC probably prescribe more retail drugs in the outpatient side than lower cost retail drugs for common ailments than what hospital-based pharmacies or providers prescribe.
Senator Mann, does that, okay. Senator Utke.
Thank you, Madam Chair. Just a couple, I guess at this time of the hearing, it's comments because we're not going to have time for answers. But as I listened to the report, it was referenced of pocket revenue, they cover operational costs, and I think really in the end, at least I come from the rural area, and I don't believe it changes all the way across our state, because you look at the revenues of our hospitals and our providers, nobody is making money. But this 340B is survival income for them. I see it across my area where they're all critical access hospitals. They're small hospitals serving our rural communities. And when I see on one column the charity care and the non-recoverable services care that they have to put out on an annual basis, the 340B revenue doesn't even cover that, but it helps keep their doors open. In future reports, I'd like to see more of that. That's information that we need too, is let's see how this really helps keep the doors open of our providers and how it's being used. It's not going into excess money that they're throwing parties with. It's just being able to show up the next day, open the doors, turn the lights on, and serve their populations. And another piece of that thing would be, for these providers, as you look at this, is what is their patient mix? We know that those that have a high level of Medicaid and Medicare percentage in their patient mix are the ones suffering the hardest, and it's just because of how they're getting paid. And this 340B has been a survival mechanism, and it's keeping the doors open. So thank you.
Senator Port.
Thank you, Madam Chair. Thank you for this report. And I think, Madam Chair, as we move forward, it just might be helpful to, as the Hospital Association sent us a letter to try to fill in some of the gaps, it might be useful to have them come in and actually spell out for us, where is this money being used? How is it being used? To Senator Utke's points, some rural hospitals, this might be a lifeline, but we're also seeing hospital systems having record profits. And I think it would be useful for us to see how this is actually benefiting those patients, see the numbers, so that we have a better idea, which this report was not able to get into.
Thank you. Senator Coran.
Thank you, Madam Chair, and I second Senator Port's statement about we got a lot more work to do, especially on this. And Mr. Gildemeister, you made a statement that you implied that part of this, that the hospitals didn't follow the law as far as requesting information, but it certainly appears they did when you requested that this request is for the dispensed drug info, and so the law was then changed and you wanted the information for administered drugs, which you'll get in April. So I think we've got a lot of information. We get pieces of information that's critical to our care system. I really think we need to bring everybody to the table and have a subsequent hearing with everybody, and a little bit more information about what's really happening out in the field. So thank you.
Thank you. I don't know if you want to have any closing comments, but
Madam Chair, no closing comments, but Senator Coran, if I implied or said that hospitals were not following the law, then I misspoke. I think the intent of the law was to not exclude certain drugs in the reporting. And some hospitals reported office-administered drugs, most did not. Either way, as you pointed out, we will collect that information in the coming months in partnership with hospitals and clinics and have a more complete picture to share with you towards the end of the year.
Thank you, and I really appreciate all the questions. I think that this was meant to get us started on this discussion, but we know that there's a lot more that we can discuss and a lot more that we could pursue. When we created the language to initially begin this process of generating a report, I think, it came about because we wanted to make a policy change, an implementation change And we found that what we were hearing was that that change was going to have a severe impact on our health systems, but we couldn't quantify it. And so we didn't move forward with the policy change in how we run our Medicaid pharmacy program. But we did say, okay, well, maybe we need to start to gather this information so we understand better the whole picture, and we understand how much money is involved in this system, and where, what different entities are using the program for. So I think that this report gives us that kind of foundational start to say, okay, this is significant. We do need to understand it better. It gives us some information about the values of the program in terms of money and what people see as it, you know, as an important source of revenue. But we need to go further. So we definitely need to understand, are there specific questions that we want to direct the department to go back to in terms of the reporting? Are there specific needs that we can discuss in our committee, different bills that relate to pharmacy programs that we can bring in more of the stakeholders who are affected, whether it's hospitals or FQHCs or other entities, patients involved, and then try and get at some of these underlying questions that we have that we aren't able to address through the report. So thank you again. I really appreciate your time and appreciate the report and all of the efforts that went into it. And members, we are at the conclusion of our agenda, and we are adjourned.